Aloha, welcome to Healthcare in Hawaii. I'm Josh Green, your host, Senator from the Big Island, ER physician, medical director for the Hawaii IPA. Over the last several months, we've had many discussions together about our healthcare system here in the state of Hawaii. But in the last few months, we've also seen a big concern nationwide, internationally especially, and in West Africa, and that's the Ebola virus. A couple weeks ago, we had Toby Claremont on our show to talk about Hawaii's response. He works for the Healthcare Association of Hawaii, does disaster relief, and gave us a very good overview on how we're prepared to deal with this virus should it ever come to the state of Hawaii. But today I'm feeling very honored to have a special guest and a good friend, Dr. Sarah Park, on my show. Sarah is an epidemiologist. She's the chief of the Disease Outbreak Control Division. She was at the CDC for some time. She was educated at our best institutions in the country at MIT, UCSF, which is in San Francisco. It's probably the best medical center in our country. And she works here as our state epidemiologist and expert on outbreaks of infectious disease. So when Ebola virus became a major problem internationally, she became the point person for the state of Hawaii to deal with this concern. So today I bring you Dr. Sarah Park.
Thank you.
Sarah, thanks for being here.
Thanks for having me.
It's great. So we've had lots of discussions about this kind of out in the community. You've been excellent. You, Dr. Rosen, have been taking the point. Why don't we start with a very basic kind of overview.
Sure.
Tell us a little bit more about your job and your role at the Department of Health.
Well, where do I begin, actually? As a state epidemiologist, that's sort of my honorary title. My official title really is Chief of the Disease Outbreak Control Division. And the division encompasses three really major areas. Disease investigations, so we basically take care of investigating and tracking any disease from sort of any infectious disease out there. What I like to say, the acute infectious disease that have public health impact, right? And then I have my immunization branch where we focus on vaccine preventable disease, and those of us in Hawaii are very familiar with the measles outbreak recently, so my staff have been very busy tracking that particular outbreak, but also doing programmatic issues doing programmatic work such as the Stop Flu at School program, where we're basically trying to prevent these diseases, right, actively prevent them by getting vaccinations out there or vaccines out there to get many of our kids vaccinated. And then of course the other major program that I oversee is the Public Health Preparedness branch, and that is really the crux of public health response in an emergency, not just infectious disease emergencies, but also other hazards, essentially all hazards response. So if there was a tsunami, a hurricane, other kinds of issues, we sort of lead in terms of helping support the community response, looking at public health, potential public health issues, and help coordinating the rest of the department and to provide the appropriate response. So I oversee all these programs. It's a lot of different, it's constantly, as I'm always telling my staff, never a dull moment, but it is, it can be challenging a lot of times, and especially when you have multiple things going on.
So it sounds like if there's a big public health crisis, it's very likely going to fall into your area, your division.
Most likely.
And therefore, when the Ebola outbreak began, and I'm next going to pivot to getting an overview from you about that.
Sure.
When that began away from the United States, am I correct? Might as well, we have not had a case of Ebola virus in the state of Hawaii.
Not in the state of Hawaii. I mean, the activity is going on in West Africa and in those three particular countries, Guinea, Sierra Leone, and Liberia, and that is where the big problem for the rest of the world lies, and that's where all our focus is right now in terms of monitoring what's going on, potential for imported cases from those areas. That's the big concern, and just preparing our state as well as all my colleagues in other states. We're all preparing for that, as well as our colleagues in other parts of the world. But really the focus that needs to be brought to bear is in those West African countries, because if you don't control the outbreak there at the source, then it's always going to be an issue for the rest of us. We're always going to have to be on that sort of leaning forward, stand up, alert sort of status.
And so that ends up being your role then. You seem to be a very well-versed educator in health policy questions on all these things, and I've appreciated going to you on issues about influenza, SARS, and so on over the many years that we've known each other. But when Ebola became a concern, when there was this latest outbreak, you probably were aware, okay, this is going to be a big part of my life for the next.
Yeah, unfortunately.
Yeah.
So, I mean, when it first started and we first started to get some of the word about it, we kept our eye on it just to, thinking that, hoping that it would, like all previous Ebola outbreaks, it would eventually die out and it would not be an issue. It would be more of a global interest issue as opposed to an actual direct potential impact for us, the United States, or even the state of Hawaii. Unfortunately, as the summer progressed, we saw it get bigger, not smaller, continue to cross borders. And then it became clear by the end of summer that now we really need to lean forward, and instead of just monitoring it now, to go into actual preparation mode, which means that preparing our healthcare systems, all our different stakeholders that are directly and indirectly impacted. It's not just the healthcare systems, first responders, but our county emergency management, state emergency management partners, various other folks, and just making certain, really at this point, educating everyone on what's going on in West Africa, what does it mean for us, for our healthcare systems, the obvious, and just making certain that our healthcare is at the level best, essentially, and especially when it comes to infection control issues. So I could go on, obviously, but I won't.
No, we're going to get to all these things. This is fantastic stuff. Okay, so why don't we start kind of at the most basic level?
Sure.
What is Ebola virus?
Well, Ebola virus in itself, even in the virology world, is quite unique. I mean, there's no other really virus like it in terms of its family. It doesn't look like most other viruses. It also is unique in that it attacks so many different cell types in the body, whereas most viruses tend to attack one particular cell type. So it is unique, and of course, unfortunately, what the media likes to talk a lot about or focus a lot about is the unfortunate sort of high morbidity, the severe outcome, which is very true. And of course, the fact that there is no cure, there is no drug treatment. However, I would say that, remind folks that for pretty much every virus out there, we have no cure or drug therapy. The mainstay of medical management for anyone with a viral infection really is what we call supportive therapy. What does that mean? You support the body, you give it enough nutrition, enough rest, enough fluids, whatever it needs. If the organ systems are destroyed or being hurt essentially by the virus, you're trying to support those organ systems. So for instance, if your heart is not pumping as well, if your kidneys are not working as well, if your liver is not working well, physicians and nurses are trying to support the body, in the ICU potentially, to try and support the body so that it can continue to survive. Because if it stays in survival mode, it's not in fighting mode, as I like to tell people, and fighting mode means activating your immune system.
Right.
And so the mainstay of therapy is trying to get the body to the point where it can actually activate its immune system and fight back. Because if we can get to that point, then person has a chance. And that's true of every virus we're talking about out there. It's just that with regard to, on the schema of things, Ebola virus is one of those that cause, pretty bad disease. However, also on the schema of things, it's not as infectious as some of the viruses that we do have out there. When you think about HIV, you think about SARS, you think about measles again.
Right.
Measles, our old friend, the quintessential most infectious virus out there, which is why we argue in public health and infectious disease, and we're always arguing for vaccination. Vaccines are our number one method of prevention when we have that tool. I mean, that's the unfortunate thing. We don't have that many vaccines against the thousands of pathogens out there. We have a handful, really, a bare drop in the bucket. But when we do, like we do for measles vaccine, we try to,
Get everyone
encourage people to get vaccinated, because otherwise you're left with, as I said, there's no cure, no drug therapy, and you really need to support the body to get the body to fight back.
So let me take you back in there a moment into the kind of the Ebola virus situation. You said it's quite serious. The morbidity, or how badly it makes a person sick, is very high, and it kills a lot of people. A couple rapid fire questions. What percentage of people who get Ebola virus, right now it's just in West Africa, die?
Now, that's a difficult question to answer, honestly, because it's shifting and it depends on where you are. And so, if you look at the literature, if you look at news media reports, if you look at past Ebola outbreaks, you see this range of proportion of deaths that's reported. Anywhere from 50 to 90% will die. 50 to 90% of people who are infected will die. That's what you hear a lot about. But you have to take a step back and realize the caveat is this applies to outbreaks occurring in Africa, where if anyone's ever been there, they would understand. But picture it's a third world country,
yes.
Continent. I'm making the same mistake that I'm hearing so much. Keep hearing people talk about it as a country.
Mm-hmm.
It's a reminder, it's a huge continent, and yes, there's an incredible diversity. You have South Africa, parts of Egypt, other places where it's not third world, but so much of the continent is still third world sort of level of living, essentially. And in terms of healthcare, capacity, there's very little. I mean, when we think about healthcare, if you think about stepping into even one of our hospitals in Hawaii, you see a patient room. Usually it's an individual patient room. Usually you see a patient call button. You see a monitor. You see the patient is usually hooked up on leads. You can monitor the heart rate, respiratory rate. That's the very basic. You might even see an IV pole with an IV fluid bag. You walk into an African hospital, and some hospital in one of these rural, not even rural, some of the urban areas of Africa, and you might see a big common room with 20 beds. There's no individual room. There are no patient monitors. You're lucky if you have one charge nurse for the entire ward.
Yes.
You're lucky if you have a physician for the entire hospital, maybe. I mean, we're talking humongous difference in terms of healthcare capacity and support.
And that's why so many people die of Ebola virus in Africa, whereas far fewer people, if there were an outbreak in the Western world, would die. And we're seeing that already in the very small number of cases of individuals that have come from Africa to get their health care in America. Maybe a couple of them have died?
Right. I forget the number we're up to in terms of how many folks have been transported for care here in the U.S. I think it's somewhere around 9, and unfortunately 2 individuals have died. But already, just looking at that proportion, it's a very small, as we like to say in epidemiology, it's a very small N, very small number of people. But even with that small number, you can see the vast difference between 2 out of 9 versus 50 to 90%. So the question is, and the other thing you could argue is that the 2 who passed away, they did not receive health care of our highest level of care at the immediate onset of illness. So you wonder then, if they had received that level of care very, very early on, would they still have succumbed like they did? So and honestly, that's what we're all coming to realize, is that the earlier someone comes to the attention of healthcare, even just basic healthcare as we have it in the United States, even in the state of Hawaii, they have a fighting chance. But if they come to the sort of level of care that's in Africa, I mean, that's
big trouble.
You just don't know.
Yeah. Well, I can tell you, we're going to take our first break here in a moment, but when I worked in Swaziland in South Africa, I saw exactly what you described. Sometimes 60 beds in a room, and unfortunately, many of those individuals were suffering from severe disease that they could even pass between one another. Why don't we take this opportunity to take a brief break, and when we come back, we're going to continue to dive into the Ebola virus.
Sure.
So this is Josh Green, Healthcare in Hawaii. I'm your host today with Dr. Sarah Park, talking about Ebola virus. Thanks for joining us.
Ted Ralston, folks, host of our show at ThinkTech Hawaii called Where the Road Leads, where we talk about technology influencing the future of Hawaii. Technology, of course, is the art of solving problems. We always bring in interesting and informed guests who can see from different perspectives and different points of view how that future might unfold and how technology can assist us in getting there. So once again, join us 4 o'clock to 5 o'clock on Fridays. Ted Ralston, your host. And please, if you have ideas that you'd like us to address on this show, or folks who you think should be on it, let us know.
Hi, I'm your host, Josh Green. Today I'm speaking with Dr. Sarah Park, who's an expert epidemiologist here in our state. Sarah has been tasked with being the point person on any concerns we have about Ebola virus. She works very closely with our Director of Health, Dr. Linda Rosen, with Toby Claremont from the Healthcare Association, with all of the healthcare professionals across the state. She really is our go-to person on this disease. So, in our first 15 minutes, we described a disease that has broken out in West Africa. We've had no cases in the United States. It kills many of its infected individuals or its victims in Africa, like you described, because their hospital system leaves a lot to be desired. We've also talked about how we have these concerns in other countries, but it's very different for us because we're in a prevention mode here in our state.
Sure.
So we haven't had these cases, but we're working a lot on this disease.
Well, just to correct you, we have had cases in the United States. Remember the two nurses?
In our state, I meant,
right,
sorry.
but not in our state, exactly. So
Very
we have
good.
had 2 cases in the United States as a result of their exposure to direct exposure to blood and bodily fluid contact, essentially. And that is how the disease is transmitted. You must have that direct transmission. There's a lot of people who, frankly, should know better, keep talking about, the potential for airborne transmission. Well, there's a couple things to consider then. If this were an airborne transmittable virus, you would expect then to see a lot more cases as a result of even that one Dallas case.
Yes.
He had a lot of contact with a lot of different individuals, close contact, even, in passing. We should have seen a number of them fall ill if this were an airborne disease and if it were really, truly that infectious.
Right.
But what we saw were 2 nurses who were with him at the sickest point, at his sickest point. So we know when patients are very, very sick at, far into their course, they're just teeming with virus, a lot of their bodily fluids. And so potentially they got sick as a result of being exposed as they were taking care of him. They probably became exposed to maybe vomitus, maybe diarrhea that was contaminated with blood.
Yes.
And, in doffing their personal protective equipment, possibly, because we know just routinely when you doff personal protective equipment, that is the most riskiest part.
You're talking about when you take it on and put it off.
Yeah,
right?
the mask, the gloves, the gowns. That's always in any infectious disease. That's always the riskiest time. You have to be the most careful because now you have all this potentially you've been working with the patient. Potentially you have fluids and things all over your personal protective equipment. You need to be really careful about taking it off. We don't know. We presuppose maybe that was where they got infected. But the reality, or the bottom line is they were infected because they were exposed to someone at his sickest time when he was teeming with virus, but no one else was. So to say that this could potentially be airborne, not likely at this point. And also the other thing to realize is, CDC and WHO and various other world experts have been monitoring this virus from the first time we even identified Ebola virus back in 1976. And they've found that there's been very little mutation from that first strain that they discovered up until now.
Yes.
So it tells us this virus, yes, viruses mutate, but it's actually pretty stable, interestingly so, over 40 years. So it'll be interesting to continue to watch it, of course, but there are no indications that this is a virus that's prone to constantly mutating on a drop of a hat. And the idea that it could pick up a mutation and suddenly become airborne, okay, well, I won't say it's completely far-fetched, but you really would have to engineer something like that over many, many years. And, it's not what people might suggest. It's not something that you'd expect to see naturally just on-off kind of switch like that.
So let me, that's so helpful. So the outbreak began in West Africa. The system of healthcare delivery, very weak there. People were in beds next to each other. When you get sick with Ebola, as you've described, you become quite sick and you're vomiting a lot, you're having diarrhea, you're having high fevers, and so we've talked about this. They spread it, unfortunately and tragically, amongst themselves in those communities. How many total cases have we had in this outbreak in West Africa? What's the ballpark?
Gosh, the numbers keep shifting and changing, and the caveat is that they have no public health infrastructure to begin with.
Okay.
If anything, in terms of a lesson learned here, this is an example of what happens when there is no public health infrastructure. There's no one like me there. There's no one like my staff who actually, on a day in, day out basis, conducts disease monitoring, disease surveillance to understand what is the expected level of disease, of any disease occurring, and to monitor for when there's an indication of a potential problem. And then when that potential problem happens, to then start doing what we call contact tracing, exposure tracing, basically looking for all the people who have disease and talking with them, investigating their situation and trying to determine who have they been in contact with, and then monitoring all of those, finding all those contacts. We've been doing this with measles, we've done this with pertussis, whooping cough.
Yes.
You know, this is what we do in the state of Hawaii and various other states and elsewhere in the world where there is public health infrastructure. When you have that in place, then you can control an outbreak much better than what they're having, you know, now in West Africa. And Nigeria is a great example of that.
Yes.
Their success is based upon the fact that they actually had not the greatest public health infrastructure, but they had the rudiments of a good infrastructure for public health because they were dealing with polio. They still are dealing with polio disease. They basically, when Ebola hit them, they turned over everyone. They gave them just-in-time training to identify Ebola disease, to understand the mechanics, understand transmission, understand other issues, and basically then sent out all these people to do the monitoring for the disease, to do what we call contact tracing, to monitor the individuals who've come in contact with those who are infected. You know, and that's the success of Nigeria.
Is that what we're doing as an international community now? You've described what happened in some of these other countries, like Sierra Leone, where the outbreak is going on, and can't even tell how many people have died from it because we might not have good records.
Right.
But now, are we sending international healthcare workers and public health workers routinely into these very infected zones, these hot zones? Are we successfully now implementing a public health system? How is that working?
You have to remember these are countries and foreign countries, so you can't just say in the U.S., oh, we're just going to send people in there,
Right.
you know, because we have to be invited. You know, these are still individual countries.
Right.
You know, just like the rest of the world needs to be invited. You can't just rush in there and do whatever you want. So there's foreign issues, diplomacy issues, but there's also other security issues. If you didn't have public health infrastructure to begin with, and these are countries, remember this is the birthplace of voodooism,
Yes.
so they have a lot of superstition on top of that. They have a lot of distrust of not only of foreigners, but of their own government. You know, there's a lot of complex issues. So just, you know, we may know what we need to do, but actually implementing it is not so easily done sometimes, you know. And there's also the issue of there's a lot of different agencies and groups and people with great intentions, but if it's not organized, you know, and that really the situation, what it really needs is one sort of leadership person or agency to sort of coordinate everyone. We learned that, you know, the U.S. and the rest of the world learned that from the Haiti response, right? From various other disaster and other kinds of response issues. You always need that sort of one lead agency, organization, and person, leader, to essentially organize everyone into this response, and so that it's one concerted effort instead of multiple, you know, different fires being put out by different folks in different ways. You know, it needs to be just that global effort together, being done together.
Who is providing care now to people of Sierra Leone, Guinea, and so on? Who is doing it?
Yeah, my understanding, I mean, I'm not there, so I can't say I'm the expert over there, you know, of what's going on. I can only tell you what I understand, from seeing the reports, from monitoring from here. And from my understanding, the clinical side is really being led, the effort is being led by the MSF or Doctors Without Borders. You know, that's the clinical side. But the public health effort, it is WHO, World Health Organization, but, you know, different countries like the US, China, you know, European countries, they're all providing their different efforts.
Yes.
One would hope, I mean, I'm not there, so I can't comment, but one would hope that they're all being coordinated in their response. My understanding is that the various countries working with WHO are trying to funnel in both healthcare support in the shape and form of personnel, but also public health support. But, you know, when you're talking about, I mean, if you look at the map, yes, these are small countries relative to the United States, you know, but again, third world conditions, roads are not great. They're good enough for people to keep spreading the disease, but they're not, you know, great by our standards to get people, public health workers out there immediately into the field. You know, in terms of flying people directly in there, you know, that's an issue. And again, the security issues and the distrust issue with the local population. They look at us as foreigners, you know, they look at the hospitals and have distrust because to them, everyone who's sick goes there and dies. They never step out, really. And so they think that if you go to a hospital, that's a death sentence. Stories go around that say, well, don't tell the officials or anyone else that you have Ebola, because if you do, they'll take you away to one of these facilities, inject you, and you die. They'll take you to one of these facilities where there are people wearing strange suits and moving very strangely, because when you're wearing personal protective equipment, you move very carefully, very slowly and deliberately. You don't look human to someone who doesn't understand, why it is you're wearing all this and why you look like this, you breathe funny, talk funny, because it's all filtered through that suit.
And they don't have those technologies. So it's obvious that it's very challenging to get to the source and to contain it, which I think is why, and what we'll talk about here probably in our next segment, why we're being so cognizant of our rules, need for some understanding of how long the incubation period is of the virus, how we ought to handle individuals who are coming into our country. We'll speak to that. Why don't we actually establish a couple of things? So we've had, it's very clear that they have a huge challenge in West Africa containing the disease. We have not had an outbreak of any consequence at all here in our state, no cases in Hawaii, a smattering of cases that have been in the mainland United States, but we've seen a lot of states react. How has that reaction response been? Are we able to contain it well away from our borders? In other words, with this large number of cases, many more than we might even know. I've heard numbers 15,000, 20,000 for this latest outbreak. How are we guaranteeing, number one, that cases don't land in the United States and spread? How is that going?
Well, that I don't guarantee anything, okay, in terms of, there's no absolute barrier. Incubation, so you asked earlier about incubation period. So incubation period for any infectious disease is that point from when you get infected, when you're actually exposed and infected by that pathogen, to when you have onset of symptoms. And it varies from infectious disease to infectious disease. For Ebola virus, what we're talking about is an average of 8 to 10 days, a little over a week. But the maximum range we talk about is 21 days. And in fact, in the literature, scientific literature, the longest documented incubation period has been about 19 days. So what we're talking about 21 days, it's being very conservative.
So
but we become conservative when we're talking about a disease with a high public health consequence like Ebola. So the thing is, think about this. If it takes you 8 to 10 days from the time you're infected to the time you actually show any kind of symptoms at all, you can very easily not realize you're incubating the virus. You're not infectious, okay? You can be walking around feeling fine, and you can get on a plane and travel, in this day and age, travel very quickly to the other side of the world. So that you can't say that, okay, well, absolute guarantee you hold everyone in. But there are certain things that are being done to try and at least, again, getting back to, people talk about travel screening as a barrier. In public health, we don't look at it as a barrier. We look at it as a surveillance tool, which is all that it is, really. It doesn't keep things in, but it helps us, hopefully, to stay one step ahead of the disease, in that we understand then potentially those who are at high risk, we can monitor them. Again, getting back to what public health does best. We monitor disease, we monitor individuals who've been exposed to disease, and we try to track it and try to control it as soon as and identify it. By identifying it as soon as we see it, we can control it. So, what's happening now is that the U.S. and various other countries are working together to implement travel screening at the country's borders, essentially before people get on the planes. And they're being progressively more aggressive about who they basically keep off the planes. In the beginning, it was sort of just educate and keep only those who are obviously ill. If you think about, and this was implemented as a result of the Nigerian American individual, or I'm sorry, the Liberian American individual who traveled while ill. And if you look at the videos, from my understanding, what I've been told is if you looked at the videos of him, he was obviously ill, and yet he was allowed to get on a plane from Liberia to Nigeria, and that's how Nigeria entered the fray, so to speak, with an Ebola outbreak. That's no longer happening now, and as a result of that, they have travel screening in place to keep these kind of individuals out. But now, as a result of the individual in Dallas, Now we have increased screening in efforts in that now people are being asked, okay, what kind of exposures, what is your daily occupation, basically in an effort to try and identify people who may have had, who are at higher risk to have had a real direct contact body fluid exposure.
I'm going to have you pause there. We're going to go to a break, and then we're going to come back and we're going to talk about how we're doing and what we're going to do going forward with containment of the disease.
Okay.
So Josh Green, Healthcare in Hawaii, joined by Dr. Sarah Park today. We're talking about Ebola virus.
Hi, I'm Jay Fidel. I'm one of the 20 hosts at ThinkTech Talks, and we have 20 shows, 4 every afternoon. One of the shows that I host is Agritech in the Islands. We cover agriculture, aquaculture, aquaponics, hydroponics, you name it, everything around agriculture. We want to show you what's going on all over the state in agriculture. Come and watch 4 to 5 p.m. on Mondays. I'm Jay Fidel here at ThinkTech Talks. Aloha.
Aloha. Welcome back to Healthcare in Hawaii. I'm your host, Josh Green, Chairman of the Senate Health Committee here in our state and an ER doc. I'm joined today by Dr. Sarah Park, who is our expert statewide on Ebola virus, other infectious disease, vaccinations, influenza. Sarah is our go-to doc when we talk about these large public health problems. Her time has been very occupied by the discussion, the health literacy question about Ebola virus. We've had no cases in the state. We have had cases on the mainland that have mostly come over as individuals who are already sick from West Africa. We were talking just
Except
a
for the
moment.
2 nurses.
And plus those 2 nurses. We were talking right before we went to break about how our country and other countries around the world are dealing with the possibility that an individual flies from an infected hot zone over into their country. You described this as a surveillance question,
Right.
that we're now getting more savvy. So what I'd like to get from you is we've now established that Ebola scares people. It's on the media radar at all times now. We've had 15 or 20,000 cases. We don't know how many in West Africa, very few in the United States, none in Hawaii. But what are we doing here in our state to make sure that if someone was traveling, we're aware of it? For instance, you told me that healthcare workers all across our state, when someone has fever or an infectious disease, we are now asking the right question. Have you traveled to West Africa? Have you had a contact? But what are we doing to make sure in our state that someone doesn't come in on a plane from New York or what have you and isn't a risk? Because you talked about the incubation period.
Right.
It's a period of time that they might not have known. So what
Sure.
do we do?
So we don't form a barrier, as I mentioned. This is more of what we're talking about as a travel screen, as a disease surveillance tool.
Yes.
But again, we're state of Hawaii, so we don't have jurisdiction on interstate travel or international travel.
Yes.
That's under the jurisdiction of the federal government. And so what they are doing is the Centers for Disease Control and Prevention, Customs Border Protection, Department of Homeland Security, they're all working together to identify with the airlines, to identify individuals who may be traveling from these regions, these 3 countries especially,
Yes.
and coming to the U.S. and funneling them, hopefully, to most of them. I understand something like 97 or 98% of them, at least, to one of the 5 major airports in the U.S. And in the U.S., that means on the mainland, not here in Hawaii. So by the time they get to us in Hawaii, they've gone through several levels of screening. They've gone through screening at the country point of origin, so to speak.
Yes.
Then if they were allowed to get on the plane, then they flew all the way to the first main, airport hub, where they went through screening there. If they passed that, then they were allowed to actually get all the way over here. Now, if they actually made it all the way over here, and they set up some sort of, even if, in the past, actually previous to even just a couple weeks ago, they were allowed to just pass and we weren't actually notified because at that point alert level was a little bit lower.
Yes.
Now the alert level has been elevated, and therefore now what's happening is the Centers for Disease Control and Prevention is notifying state health departments, so not just us but our colleagues across the nation, if they know of a traveler coming from one of these countries that is now entering our borders. And so we're actually notified before they even land whether this person had traveled to Liberia, to Guinea, when they left, what was their travel itinerary, when are they expected to land. And so for our part in the state, just like every other state, we are now engaging in what we call active monitoring. And it does vary somewhat from state to state. In Hawaii, we want to make sure that people, when we do engage in this kind of active monitoring, we're employing science, evidence-based medicine, right? And practical public health methods, and not just bending to, frankly, political will, or hysteria, essentially.
Which was the concern we had in New York and New Jersey,
Yeah.
right? Where that's very clear to me that it's better to approach this from a scientific standard,
Right.
which means that people like yourself, experts in epidemiology, are running these
Right.
programs rather than political
Right.
institutions. But how do we get around certain other challenges? I take it to heart. So what you've said is we're very well prepared now to track individuals who are
Right.
traveling from the region. Especially
gets-
but if I may though, that's if they come through the United States mainland and then to us. But what happens if a patient, an individual I should say, has worked, say in West Africa for a period of time, leaves West Africa, and let's say that they're a healthcare worker in Japan or in China,
Sure.
and then comes over. Do we have a similar mechanism to make sure that we don't have an infected individual coming into our state?
Sure. On that side, there's always a backdoor, if you will, in which case we have tried to encourage our, get the word out, encourage our partners out there, travel partners, healthcare partners, and various other folks, to let them know who to call in the department, namely my staff, essentially,
Right.
if they're aware of an individual who's traveled from one of these 3 countries and is now in the state of Hawaii, just to let us know, because then we want to touch base with that individual. So, there's always the potential that they won't come in through the recognized route, they'll come in the back door. And I've met with the consul generals or their representatives to talk about this issue as well. And so really we're pulling on the strength of Hawaii, our relationships, know who do you know, trying to inform each other, and based on that, hopefully we'll capture at least 99%, if not 100% of individuals who might be traveling from those regions. But I might want to just stress, we're a very low risk state. I mean, the idea that someone is just going to randomly come here, it's very, very low. It's always possible, which is why we prepare.
Right.
But we're compared with a state like New York or Massachusetts or California, we comparatively much, much lower on the number scale.
Right.
But the possibility always exists. So getting back to the science, I just want to talk a little bit about the active monitoring issue, because you had mentioned governors of New York and New Jersey, and what happened for those of people who don't know,
Right.
and happened in other states as well, as governors basically summarily decreed anyone who had traveled from those 3 countries automatically go into quarantine, meaning they're restricted to their home for 21 days, or at least 21 days from the time you left Africa to the, however long that takes.
Right.
That is not based on science, because if you remember what I said, you're not infectious when you have no symptoms.
Right.
During that incubation period, until you have symptoms, you're not infectious. So to say, well, you have to be restricted in your movement, absolutely, and stay at home for that entire time, but you're no threat to anyone else. So how do you rationalize that? So what we have said in state of Hawaii and in various other states that do agree with the more scientific method is, yes, we recognize that this individual was in a high-risk situation. They potentially could have been exposed to bodily fluids, to blood, contaminated blood. And what we're choosing to do is check in with that person as soon as they step foot in the state of Hawaii, make sure they understand who they can call, where they can go for help. That's really important, because they know what the risks. Let's face it, they know what's at stake. It's their lives. So we want to make sure they know who to call for help, and they're not out there wondering, okay, sitting at home or out in, who knows where, and just really confused and not knowing how to get help. So that's number 1. Number 2 is then establishing with them a routine. During your 21-day period, or maybe by the time they get to Hawaii, it's only 18 days or 17 days. So during that period, okay, depending upon what level of risk we've assessed you at, low or some or high risk, depending upon what you were doing out there in West Africa, we'll decide with you Okay, how often are we going to check in with you? Make sure everyone from the get-go is going to monitor their temperature twice a day.
Have we had any of these individuals yet?
We've had at least one or two that we've actually checked in with, low-risk individuals essentially,
Yes.
who were not in a healthcare delivery setting, had been out there, and basically they agreed, take their temperature. They knew the drill, take their temperature twice a day. We checked in with them periodically during the 21-day period, and then we have a final evaluation with them, and basically, essentially a blessing, let them know, you're good, you're fine, thank you very much.
And no cases.
But if someone had traveled, I just want to point out, if someone had traveled, you hear, maybe 3 months ago to Sierra Leone or Guinea, or
They're
30
not a
days
risk.
ago, they're
Yeah.
not a risk. I really don't care about them. They have to be have traveled within that 21-day period.
We also have military individuals that are in the field, and I understand that we have a military health system as well. Now, the military has instituted a plan, right, to prevent, I think I read about it in the newspaper, to prevent any possible additional concern. Is that something that you're able to connect with? Are you able to be in communication with our military affairs
Again,
officials?
it's playing on our strengths in Hawaii, our relationships. We know each other. They know who I am. I know who they are. They know that they need to call us if there's an issue, and they will. I've had reassurances from them, and they know there needs to be one concerted effort. Yes, the military have come out with their own recommendations for all their folks, and that's fine. That's what they choose to do.
Right.
They're on a different sort of field.
Right.
But again, we still choose to follow science, and science says that these individuals are not a risk during the incubation period, but caveat is we need to monitor them. We need to engage what we do best in public health. We monitor them for signs and symptoms. We make sure they understand where to get help. And depending upon their level of risk, we might ask them to restrict their movements. Very different from restrict to house, okay? Essentially, for instance, if you have a healthcare worker who was engaged in direct healthcare delivery in West Africa, we would ask that person, please not engage in direct healthcare delivery in Hawaii, in the state of Hawaii, for the 21 days. It's not because we think that they're infectious. It's purely because we can't predict if and when they might become sick.
Yes.
And we want to limit the potential that if and when they become sick, they're around people who are very vulnerable, patients essentially in the hospital setting.
That's extremely helpful for people to be clear. We're running up against the end of our television time here today, so I just wanted to kind of reassure people and disavow me of any of these comments if I'm not correct. We've had no cases in the state of Hawaii.
Right.
We do have a comprehensive monitoring program and a way to find out if anyone were to come to the state of Hawaii, whether they run any or pose any extra risk to our citizens. We have not discussed it today, though we did in our previous segment, that we have a very detailed protocol that if an individual had a risk, they demonstrated risk factors, they had come from a region that had Ebola virus, and then had symptoms or signs, we are able to implement a protocol to get them care. We isolate them, we get them into very modernized, standardized care at our key facilities. We have 4 facilities, I believe, that can offer intensive care units 24/7. They're well designated, they're ready to respond, and we have all of the equipment that we would need. Are we prepared in those cases if we were to have a case?
I believe we are. I think we're well situated. And again, nothing is 100%. Despite our best efforts, there's always going to be a potential loophole. But that's why we continue to prepare. We never stop. And we do what we do best in public health. We continue to do that, engage in that effort.
Okay, and right before we close, Sarah, if someone had a concern, who do they call?
They can always call. We have a 24/7 duty officer, disease investigation duty officer, if they have any issues, whether it's Ebola or foodborne disease complaint, or there's a flu cluster, measles cluster, or just a random question. You can always call our duty officer. It's 808-586-4586. And we're always on, and we're always available to help the public, because that's our mission.
So I'm so pleased you were here today. I think that health literacy is one of the most important things about an issue like this. Let me just say in closing, I know that you've done an incredible amount of work on the Ebola virus and protecting our state. I feel as though we're one of the most protected and prepared states in the country, but all of this work, from what I gather, is going to give us additional protection in the future for other outbreaks, other disease.
Right, and I just want to acknowledge my staff, because it's not just, I'm just the figurehead, I'm just the face, but I'm incredibly fortunate to have a great team that are working very hard to ensure that we are prepared in Hawaii. I mean, without them and their dedication, none of this would be possible. So.
Okay, well, thank you again. It's great to have had Dr. Sarah Park. This is Josh Green with Healthcare in Hawaii. We'll see you again soon. But Hawaii is safe from this infectious disease because we have good professionals like Sarah Park and her team. Thanks for joining us.